So, Stefan Felder, I would like to start with you. You have been in Lithuania as well, and you have heard now these presentations, these insights into the Lithuanian healthcare system. What are your impressions? What are the most important lessons you would take from there for the Swiss healthcare system?
I think we are different, right? Switzerland is quite different from the Lithuanian system. I think they have a single payer system, whereas we come out of a private health insurance system. And that makes a huge difference. And most impressive, that also this morning we heard that, was that the reimbursement of physicians is totally different there compared to us, right? We have heard the number, 75% of the income of a physician is capitation based, mm-hmm. and fee-for-service only 9%. And here it is the other way around. Mm-hmm. So I think there we could make much progress, and it's very slow, and we go forward just a bit by step. But this, I think, is the most those two things, right? The reimbursement of physicians and mm-hmm. how the insurance market is organized.
Mm-hmm. And how about the digitalization, especially what we heard at the hospital level?
Interestingly, we also have this information here in Switzerland, but it's not made transparent. Mm-hmm. So their information also is based on the DRG system and medical statistics, mm-hmm. and basically we also have this information here, but it's not used, and it's not centralized, right? That's why it's so difficult. We can only have a look at it 2 or 3 years later.
Mm-hmm. Yeah. Maybe Felix Neuli, your impressions as well from Lithuania and from these presentations?
I think it's, as I said in the beginning, it's a public system. 98% is public and only 2% is private, and according financing. And what impressed me is the entrepreneurship of this private sector. So,
of this public sector, maybe.
Of this public sector. If we discuss it in Switzerland, so we say, many people say, the healthcare system has to be public, and they say, profit. It had nothing to do in a healthcare system, and they merge public system with entrepreneurship. And
but it's what you said. You are aware that the money you spend is public money, so you have to take care. It's kind of a cultural thing. I'm happy to have Thomas Lapinskas here. He is the Director of Public Health Studies and Research of the University Hospital of Kaunas. So would you like to add something to the presentation of your boss or so, maybe?
I still want to have a job after my...
We are among us, nobody...
Yeah, no. Indeed. Good morning, everyone. It's a pleasure to be here. Yes, these digital solutions are very important, not only for the performance of the hospital, but we are foreseeing the future, and the research for the university hospital is a pillar, as every one of us knows, and capability starting from the students, just to give them opportunity to access the data and make the research, but also you're reaching the next level for clinical trials and for the personalized medicine. And we are also starting to implement some artificial intelligence solutions from this, just helping doctors just to make their electronic health records, just like Scribe. They can spend more time with patient, and AI tools can help you to make all the records. When we speak about this digital data, we still have quite a lot of unstructured data. This is, I think, also important. And how can AI can help us to structure data these tools can make a structure prospectively when it was just talking with the patients or making investigation and reporting. So it can make and help you make it structured, but also from the retrospective data, if you apply some AI algorithms, it recognizes some text or some variables and structures it afterwards. I think that's a huge step forward.
Maybe a question to Gitis Bendorius. I was wondering, as you have quite a lot of power, you are and giving a lot of power and then pressure to the service providers of the healthcare system. You want to talk about the contracts every 3 years, don't you have some people who say, no, Mr. Bendorius is too powerful, or politicians who want to limit this power of your healthcare fund?
Yeah. So, of course, with great power comes great responsibility. So, we experience some pressure from politicians, especially in when it comes to discussion about changing the model of the financing. For example, how to keep, politicians raise the question, how to keep a small local hospital alive. And if a hospital...
Same here.
Hospital becomes loss-making and they have financial troubles, so most often politicians come to us and they say, improve your financing structure or fees or whatever, but they very seldom go to the hospital and say, why are you loss-making? And of course, when Lithuania, 100 years ago, we are a very farmer country, so 90% of people lived in the countryside. Now agriculture is important, but about 3% of the people are employed by agriculture. So everybody is moving to the bigger cities. And of course, small hospitals, we are dying. And there is a big question, how many of those we should close? And this is not my decision, but the pressure from politicians, yes, we experience that. We try to resist. I'm not appointed by some, I'm not on rotation, not dependent on the parliament elections, but to fire me is a couple of days' work. So for the healthcare minister. So yes, there is a pressure, but there are rules. I'm not dividing funds myself. There are quite strict rules. And this autumn there was a big pressure of one hospital which said that we are making so many operations. Please pay us extra. But we set a rule that we will pay extra, but a little bit extra if you exceed your contract, but not double or triple whatever you want to do. And he was so angry, was involved everywhere, on the press, everywhere. But we resisted. We said, okay, rules are rules, and they are equal for everybody. And somehow that was later on a little bit accepted.
Have there been hospitals that have been closed, and have they been closed because of patients who saw maybe for cardiology we better go to Kaunas, and therefore has there been a competition between hospitals that became difficult for the smaller ones?
It's somewhat not so public. It's more word of mouth, but I will be better served in that hospital, even though we publicly we have a rating, and we can say that in this hospital the chance that you die after heart attack is 30%, and in Kaunas Clinic it's about 8%. So there's a big difference. But the person in a small city with a heart attack most likely is not, checking the charts and and dashboards. So he just goes there. Most small hospitals were dying slowly. They are closing surgery departments, switching to day surgery. They are closing pediatric department, switching to daycare. So this is very, very slow.
Maybe
process.
A last question, Professor Jurkevicius. When you introduced this system of 98 indicators and enumeration on quality and on outcome, how did you overcome the maybe some physicians were totally against it and said, if you start doing that, I'm going to Poland, to the UK or so. It seems quite a wonder from a Swiss perspective to introduce that.
A very difficult question.
Just tell us how you did it.
It was very autocratic.
Okay. Good answer. Maybe you want to react on that, Felix or Stefan?
What he said it, but it's not only autocratic, it's data-driven. And I think that we should learn also in politics more data-driven decisions. If it's a management decision, if it's a political decision, it has to be more data-driven.
Then you can say it's a fair decision. It's about fairness.
Facts.
Yeah.
Not fake news.
Yeah, Stefan?
But I noticed that only doctors, and you said that are on charge, right? No economists, no business administration people. So you are driving. You are on the seat and you're driving the tractor. That's quite amazing.
Maybe yes. Our economic service should help doctors. They should help. They are not taking decisions. Doctors should take decisions because, in our opinion, we know better what we need for us, for our patients, and talking more seriously about implementation. Some difficulties. We decided not to give money back to us. We are giving on ad. If you will do better, you will get more than you today have.
So you worked with incentives,
not with penalties. With incentive, not with the penalties. Looking at data, very very easy manner we are getting. With working algorithms, we can extract data from every department, from every physicians, and show to our heads. Look at the numbers. You have worse numbers this year than the year before. What was happened with you? Maybe you have excessive staff. Looking at your services you are provider, maybe you don't need, and what is good for administration, we have now less coming to us, heads of the departments, asking for additional staff, additional nurses, additional premises, if you don't need, because it will be, if you will not cover with services staff, additional staff, you will get less money. And it make our life more easy.
So you break the incentive of departments getting bigger and bigger and bigger without keeping up with efficiency, at least. Mr. Mendoza?
Yeah, I would like to react to that what Professor Irkevicius mentioned, it's very important still to keep quality parameters as well, because it's very easy to go just to quantity, and partly we see the risk of this type of incentive for the doctors, and we can see constant kind of upcoding in Kaunas clinics. So cases become more and more complicated. For example, bariatric surgery a year ago, about 20% were complicated. But now, this year, about 40% are complicated cases. And of course, we pay about 2,000 euros more for the complicated case. Most of those are validated, and Kaunas clinic is still behind Vilnius clinic, which are similar size, also about 350 million euros budget. So Vilnius is coding even better. So more complicated, interesting cases. But there is certain risk when when you give too much incentives for the profitability or quantity, there is a risk of small, upcoding practices. But overall, we went together with a reputational self-esteem part for the doctors and quality parameters should work quite well.
Mm-hmm. So the quality parameters are your tool to go to?
No, it's internal.
Yes, but you are comparing quality to tell him don't do only quantity.
Those top 10 hospitals were so much better, but they are always above the national average. Mm-hmm. So it's quite difficult to compare. Usually, small hospitals we compare to the national average. They say mortality after stroke, mortality after heart attack, reoperation after hip replacement. But those big hospitals we compare to European average, mm-hmm. because we say, okay, Lithuanian mm-hmm. average is not good for you. It's too easy. So,
now,
and we are doing quite well.
Yeah. Now it's time for your questions. Over there, just at the table over there. Hinedra am Tischli. Yeah.
Thank you very much for your very interesting and comprehensive presentations of your system. What I wonder is, you presented mainly inpatient and outpatient care, or a focus on inpatient and outpatient care. Where do you see the potential for integrative care and integration of home care facilities, for instance?
Yeah, who wants to?
Because we are hospital, university hospital, of course we are orienting mostly on the inpatients, but also doing a lot and increasing numbers for outpatients. We have a small family physician clinic between us for teaching purposes, because as a university hospital we are teaching our doctor residents also, a lot of them, and we have also what you are asking, but only in small amounts, integrated care, but it's not so easy to have integrated care, and over the world, I don't know, maybe we don't have a lot of very good examples. We have, of course, good idea payment systems to change, because payment for services can decrease quality, because we all oriented to do more and more and more, and the quality can be diminished, and we should look at the results. But to implement more modern system in the world is not easy. Maybe.
Can I just interrupt you?
Yeah.
Prevention is important. Please make everyone one step to the front. Otherwise, I really fear that someone is falling down. Now, Ms. Bendoyos.
Yep. Where we are really lagging behind is long-term care or nursing at home and nursing hospitals. So those are under development. We compensate more nurse visits to people's homes. Still under development. There was a lot of cheating last couple of years. We had even some arrests made with one company issuing invoices for approximately 1 million euros and never visiting a patient at home. So now we implemented limitations, how many home visits a nurse can do during a day, not more than 10. If he or she is full-time employed, and that person has to carry a GPS device, and this GPS tracking should be available for us for inspection at least 1 year after the service was provided. So now it's Big Brother watching.
And you are the big brother.
Yeah. but how to make sure that when that nurse is at home with the patient, there is a good care taken of. This is a big question, of course. Currently, our healthcare minister and social care minister, they are under discussions how to integrate elderly homes with nursing homes, because quite often the boundary is not very, very clear. We are looking a little bit into the Finnish setup. They are quite good, and then municipalities usually run this type of integration. But there is no clear answer to that. So you are very right to raise that question, but no good solution for us, and we are still making our mistakes and trying to catch up.
Next questions over here.
Are community pharmacies involved in prevention or taking care of common problems? Are they paid for it?
Pharmacies, they dispense pharmaceuticals, and we are paid for that. They can vaccinate, but we don't pay for that. This is out of pocket for the patient, and we pay a family doctor provide the flu vaccine for elderly 65 plus, which costs some €2.50, so it's almost nothing, and we pay about €6 for every vaccination for a family doctor or nurse. So and we have very bad results. About 20%. 65 plus are vaccinated. So our idea was maybe we should pay the same amount to pharmacists, because pharmacists were really greedy and flexible folk. So for 10 euros extra, it's quite likely that they will vaccinate extra 20% of the population. So we think we would push into that direction as well, because most likely there is unutilized clever professionals very close to the patient, but those are only a couple of ideas what we are doing today. We were thinking about this review of pharmaceuticals, like Dutch. They have this type of some 20-minute talk with the patient and going through all the medications, but that was not implemented yet. Only ideas.
Another question over there.
I have a question regarding data flow between the university hospital and the family doctors. Is it digital? Is it structured data? Is it documents? Thank you.
We as a university hospital are transferring data to national system, and every family physician working with this concrete patient can look at this data. Also, patients can look at his or her data, and also we can, if we have, of course, all our patients has family physicians, and coming from them to us in many cases, and we can look at all data, all visits in family physician offices, in either university hospitals or small hospitals. We can extract data when we have this concrete patient at our hospital. We can get all data what we need about this patient from national system. This exchange.
And do you have all the data, or is the patient allowed to say, okay, this kind of report I don't show to the cardiologist in Kaunas or so?
Maybe not all, not radiology images we don't have it yet, but epicrisis summaries, of course we have all summaries, we have all prescriptions, we have summaries from other hospitals, and nowadays we are using artificial intelligence tools to collect this data and to make summary for physician. If we have appointment of the patient, I have a patient in my outpatient room, I ask algorithm to make a summary, because you as a doctor spend a lot of time. If you have a chronic disease patient, you should look for several hospitalizations, for complications, what kind of operation it was done, what complications after it was, what prescriptions, what adverse events of medication has patient. You can ask artificial intelligence make a summary from all these data. It's very useful.
Another question?
Maybe I will add a small comment.
Of course.
This National Electronic Health Record keeps all the data from family doctors, specialist visit, outpatients. But from a hospital, there is only a summary which goes into national electronic record. So if after the hospital the summary mentions something, what was done, it's okay. But family doctor cannot go inside the hospital system and see what type of laboratory testing was intermediate, not at the start, not at the beginning, or at the end of the treatment. So this is not so detailed. So only summaries are transferred.
What is the reason for that?
It would be too complicated to get everybody inside into the hospital.
Too much data.
Yeah, could be. But then for that is those data banks are used for populational research. Those are also valuable.
Another question? Over there?
But for the data that you share, there is a national standard, no?
National standard of data sharing? Yeah. Indeed, it exists. Oh.
Thank you.
Then, Fridolin.
You pay the family doctors by capitation. Do you attach quality indicators with that capitation, or do you hope for the best that they won't shrink?
Yes, the quality indicators are not attached to this capitation part. So if a doctor has a list of the patients, and so then he will get about 70%, 80% of his income anyway, but the patient is free to leave every time. And we pay family clinic based on the number of their patients at the end on the last day of a month. So if patient switches, let's say 2 days before the end of the month, so to another clinic, so we'll pay full amount for another clinic. So maybe this works a little bit, but you're right. The quality part or quality KPIs currently are not used very much on this. But whenever we start discussion with the Association of Family Doctors, we say, but patients are so different. Even if they are the same age, some are very healthy, 50 plus, some are multimorbid. And my population is, trouble on trouble. So it's quite difficult to compare. So that's why we went to Spain to check on their frailty index and additional classification of the patients, how complicated they are. We looked into the Hopkins score, which is more complicated, and you have to pay Americans for that. It's not. So let's see. Most likely we'll introduce some difficult of a patient score inside, and maybe later on we'll try paying according to the in a more subtle way than today.
Is there a transparency on the quality of the family doctors? Do I see how
not today.
Not today. Okay.
But good idea.
Thank you very much. So now we have a pause. We are a little bit late, but we are getting there. Thank you very much. Our Lithuanian guests are here. Please ask them, take the chance to ask them more of your questions, more of your interesting thoughts on their system, on our system. Thank you very much to the panel, and we see us in 25 minutes.